Now I will invite Dr. Nidhi. Dr. Nidhi to speak on retinopathy of prematurity and its relationship with anemia. Dr. Nidhi is consultant at NMCH Sasaram, Bihar, and this is associated with the Narayana Medical College and Hospital.
Good afternoon.
And this is an extremely important topic because the number of children detected with retinopathy of prematurity, and there are lot of issues of concern in this. First is detection, then is the management.
Good afternoon, one and all. Retinopathy of prematurity is a vasoproliferative disorder of retina occurring in preterm babies having immature retina. And it is a potentially blinding condition. The image represents impact of ROP and distribution across the globe. This circle is all the babies affected by ROP. The darker color wedge represents babies severely affected by ROP. We can see that the impact is more in South Asian countries compared to high income countries, and also in low to medium income countries from Latin America, North Africa, Eastern Europe. So why should we screen for ROP? First of all, the premature babies are not born with the disease. They develop disease with due course of 4 to 5 weeks. So we get a window period in which if we detect and intervene timely, the potential blinding condition can be prevented. Who should we screen? So according to Rashtriya Bal Swasthya Kalyan, we have to screen all the babies with birth weight less than 2000 gram and gestational age less than 34 weeks. Babies larger and between 34 to 36 weeks has also be screened if they are associated with risk factors. First screening has to be done at 4 weeks of birth. For smaller babies and born before 28 weeks, we have to screen at an earlier time, say 2 to 3 weeks of birth. After first screening, we have to repeat screening every 1 to 2 weeks until the retinal vessels mature, ROP regresses or progresses to a stage where treatment is required. There are more than 28 documented risk factors for ROP, in which birth weight and gestational age are the most important ones. Supplemental oxygen administration is an important modifiable risk factor. Other commonly encountered risk factors in literature are sepsis, poor birth weight gain after birth, and anemia, blood transfusion, multiple birth, and the list is long. Let us look at impact of anemia as a risk factor for ROP. This graph is taken from a study from South India. It shows severe anemia, that is hemoglobin less than 8 mg per dl is associated with increased risk of ROP as compared to less severe form of anemia. A similar study was done at our center which showed comparable results in relation to hemoglobin level, and it also showed increased number of blood transfusion are associated with increased risk of development of retinopathy of prematurity. Coming on to pathogenesis, retinal vessels start developing at 16 weeks of gestation from optic disc, and they move towards nasal ora serrata. They reaches nasal ora serrata at 32 weeks and temporal ora serrata at 40 weeks of gestation. So what can go wrong in premature babies? When the baby is in utero, there is certain level of IGF, insulin-like growth factor, and VEGF, which is required for the maturation of the retina and development of blood vessels. When the baby is born prematurely, because of hyperoxic condition, there occur downregulation of IGF and VEGF. This leads to temporary cessation of vessel growth. The retina peripheral to the vessels become hypoxic, and they send signals for increased production of IGF and VEGF. When IGF and VEGF reaches a certain threshold level, neovascularization start developing. Two things can occur: either the VEGF level spontaneously decreases and there occur resolution of ROP, or it progresses to become proliferative retinopathy. These new vessels are associated with fibroblast. These fibroblasts leads to scar formation. When scar tissue contracts, there occurs retinal detachment. Coming to classification of ROP, ICROP2 had classified in 2005 retina into 3 zones, zone 1, 2 and 3. Zone 1 is a circular area with diameter double the distance between disc and macula. Zone 2 is area beyond zone 1 with diameter from disc to nasal ora serrata, and zone 3 is the left out crescentic part. In ICROP 3 2021, another term posterior zone 2 was introduced to mention about the more severe form of disease in zone 2 compared to more peripheral zone of zone 2. This posterior zone 2 is an area of 2 disc diameter away from the zone 1. ROP has been classified into 5 stages. Stage 1, in stage 1 we see a demarcation line between vascular and avascular retina. In stage 2, this line gains volume and becomes a ridge. In stage 3, we see extraretinal neovascularization at the level of ridge. Stage 4 and 5 are the stages of retinal detachment. Stage 4 is partial retinal detachment, in which 4A is with fovea attached and 4B includes foveal detachment as well. Stage 5 is total retinal detachment. Plus disease, it's a severe form of ROP in which there occur dilatation and tortuosity of retinal vessels. Now in ICROP 3, it has been emphasized that this should be assessed with vessels in zone 1 rather than peripheral vessels. Another important term is aggressive ROP. Previously it was termed as aggressive posterior ROP, which was seen in severely premature infants, and it was more located in the posterior retina. But now it's seen from developing world more so. It occurs in more older babies and also beyond posterior retina. So the aggressive posterior ROP term is replaced by aggressive ROP. It shows looping and shunting of vessels with severe plus disease. The hallmark of the disease is that it does not follow through the typical stages of ROP, rather it progresses to neovascularization stage rapidly. Notch is another important term introduced in ICROP 3. It shows 1 to 2 clock hour of incursion of the disease into the more posterior zone. Early treatment of ROP in 2003 came up with guideline regarding treatment of ROP. It classified ROP into 2 types. In type 1 we have to treat, and in type 2 we have to do follow up. Basically we can understand it like this: all the disease with plus we have to treat, only disease where without plus we have to treat. It is neovascularization in the zone 1, that is stage 3 zone 1 we have to treat. One example of follow up, the disease which has to be follow up is zone 2 stage 3 without plus. Coming to treatment, laser is the gold standard. Diode and green lasers are used with the help of indirect delivery, laser delivery system. Intravitreal anti-VEGF agents are not yet the standard treatment. Because of long-term safety concerns, there has been reports of neurodevelopmental delay, and also the recurrence rate is quite high and unpredictable. Follow-up of these babies are very much required to prevent impact of myopia, cataract, glaucoma, retinal detachment, strabismus and amblyopia, to enumerate few. So the take-home message is ROP is an important cause of preventable blindness in preterm infants. We should be aware of the high risk like extreme prematurities, oxygen therapy. So proper documentation and timely referral is a must. We should take second opinion whenever in doubt, and we should be aware of the medico-legal implications. Thank you.